Hi, it's Jenny B and SWOC back with another episode from our time series, Living on the Edge. Well, just couldn't help myself from making that reference. Anyhow, this wound today that first one I'm going to talk about is, again, a healthy versus unhealthy edge. So again, when we see these types of necrosis, for the most part, we know we need to get rid of them. We know that the edge, there's something unattached underneath, and we need to actually explore. So this is something, again, that would require some surgical debridement, which again, once we remove that, then we can actually see where the bottom or the base of the edge is. This one, as you can tell, as soon as we inserted it, there's some soft, boggy areas. Usually you're able to then poke through and open it up. So again, this is one that would likely require a surgical consult, because then you're going to get a nice clean edge all the way around, opposed to the dead or devitalized tissue that you see presently. Here's another one of those incisions, again, one that's there's necrotic tissue that we do need to clean up. You can actually see a small hole here where it's not attached, and you know that there's actually depth within and underneath. So this one we had to actually cut all the way around to remove some of the devitalized tissue, so we can then get a good, nice, clean edge to pack. This here is a skin graft. These are actually quite common that we see when we have removal of lesions. We do a lot of excisions here for SCCs and BCCs. This gal, we took a piece of tissue from this part of her ear, and then the tissue was then placed over top of where the lesion was excised. So we can see that the edges are quite dark, that we're seeing some necrosis. So sometimes this is going to actually be from the sutures, that they're a little bit tight, or that the the edges didn't quite take. Sometimes patients have other factors that can cause the healing to delay. But for the most part, we still wanted to do these and fill them. We don't tend to leave them open, because again, that's what can open them up to bacteria and bugs when they're just out in the exposed air. So if you do see a graft like this, yes, some of the graft didn't take, but we do still have healthy tissue in the middle, so we don't get too concerned. We can debride the devitalized tissue that happens later on, but again, filling that deficit or that hole was usually of the most importance at that time. So you will find that these edges are not attached either, because again, there has been some necrosis or ischemia that's caused them to die along the edge. This here is a piece of hardware that we have inside a wound. The edges look nice and clean and healthy, which they are. However, the wound itself will never actually epithelialize or granulate over, for the most part, with the hardware that's exposed. Sometimes we actually have underlying infection in the bone, and often it's just the easiest way to treat this is to actually remove the hardware. Prior to this was the after photo after we cleaned it. This actually had quite a bit of granulation tissue over top of it. And I will tell you, 9 times out of 10, if you do see granulation tissue present on anywhere along an incision line, especially when you know there's hardware, usually that's a sign that the hardware is actually trying to come out, and you will find hardware underneath. So yes, always explore that hypergranulation. Usually there's something in it, because it can be just a foreign body. If you don't know there's hardware, sometimes it's something completely different. I pulled out glass, I pulled out tacks, I pulled out wood, pulled out things that I didn't know that could actually get into wounds. This here is a large flap that was that's done on, it's actually on the scapula on the shoulder, and it dehisced. There was a lot of tension on the suture line. The patient just wasn't quite healthy. The tissue wasn't quite healthy. It is much more so now that it was actually able to stay together, and the tension caused it to open. I will note here, underneath here, I can actually insert my hand. My hand actually fits underneath this graft. There's an incision over here. This is where they actually twisted and turned. But then again, this part popped out. So I can actually put my hand under here. So there is some undermining. This is a great sign of what an unattached wound edge is. It's very healthy, but the edge itself, it's not attached to what the base is. So when I talk about the BWAT, this is really what we're talking about by it's not attached. There is depth, and we actually have to have the granulation come up before we're actually going to get contraction of the wound edges and get it to heal over from the sides. So in this case, we have to make sure that we do get something into the undermined area so that we can promote it, because sometimes the graft itself, it hasn't attached to the wall. And again, it's going to take some time for this to heal. But again, a good example of a non-attached edge. Another one that we've done surgically. So I like to point this one out here too, because there was what's called epibole that I could see prior to actually opening this, where the edge has actually had rolled up and was attached to the other. And the only way that I was going to get it unattached was by opening it so that, again, that rolled edge, that rolled up, could flatten. Well, when we started getting into it, we actually found a very large seroma, a large cavity, so then we did have to open this up. This is actually a breast incision. So underneath here, there was quite a bit. It's not just there's bleeding now because it was opened. A lot of yellow serous fluid, and that all had to come out prior to being able to actually try to close this wound. So this is very similar to that other flap where it's an unattached edge. This isn't attached to the chest wall, so we actually have to try to get that to attach down before we're going to get anything to contract or crawl across, which we finally did. We were able to use negative pressure wound therapy to close this wound. But again, a great example of sometimes, we think there's something, but sometimes there's something more underneath. So this is a nice healthy edge now. Again, and we did get her to full closure. So here's a good example. I see this actually quite often in those with a below the knee amputation. They may have, at the time of the surgery, had some difficulty with the wound healing, or they, again, the anatomy that's left over is a little bit, there's a small deformity, and so when they've actually gone into their actual prosthesis, it's caused some skin damage. So this case, again, sometimes the skin bunches up because they're constantly putting their limb into this prosthesis, and you can actually get this extra skin that builds. This fella, in this case, you can actually see there's an actual new wound edge all along here, and it's actually about this deep, and there's red granular tissue underneath. So the wound edges can also be deceiving. You can't actually see that this is wound edge. You can tell that there's maceration, that there's moisture there, but you can't actually see the edge. So again, this was one that we've actually had to pack down into the actual wound because you can't see a very well-defined edge. So this is an undefined edge. So because you can't see where the base is, where it is, because it's down in the base. So this is another graft that, again, had a bit of tension on the sutures and caused some necrosis. So once we were able to remove some of that, again, we can see all along here that edge is also unattached, and again, we'll need to granulate up so that we're able to heal this. Due to the erythema, we also checked for infection because we were getting that greater than 2 centimeters around the wound edge, and again, some antibiotics to help once we'd identified the bacteria. Now, this was an abdominal incision. It was actually for a bladder repair, and the patient was on some anticoagulant therapy that caused a hematoma right in the middle. So once the sutures came out, and you could see this large black bulb, again, we know that the edges, again, now are not attached whatsoever, and there's going to be quite a bit of depth inside. So once this was irrigated and removed, and removed the sutures, we were actually able to heal it via secondary tension from the bottom up. So here's another great example of an undefined edge. We can't actually see where it is. We do know that there's an edge somewhere along here, but again, there's new tissue, there's dead tissue, there's yellow tissue. It's kind of all over the place. So this is definitely one that if we are using a BWOT, we're going to say that the edge is undefined because we're not actually able to see it. We do know that there's generally in this area, but again, we have to wait till the majority of this is debrided before we can actually see where the edge actually lies. Undermining is another. This is epibole as well, where we have a rolled edge or thickened edge. Yes, there's some maceration, but it's definitely one that we also need to explore because, again, this isn't attached at all. We're not going to get any healing until the bottom is actually, we can see the base, and then the edges attach at the end. So we have to fill this deficit until then. And then last but not least, one of the most common edges I do see is a calloused edge, especially in a diabetic foot ulcer. This is one that's actually been pared back, but these can actually grow over and be quite cumbersome to the patient. When they have neuropathy, they don't feel them, but some people have a little bit of sensation still, and they can, and it definitely feels like a stone in their shoe. So if we're not paring back those calluses, again, and exposing the actual base of the wound, they tend to heal over and then they can become infected. So again, it is quite key that diabetic foot ulcers are getting the callus debridement anywhere from 2 to 4 weeks, done routinely. This isn't something that is provided or covered, which is why it's definitely a challenge for a lot of these patients if they don't have the funds to actually go to a chiropodist and have this done. We will do this in a wound clinic as long as they do have a wound, but once that wound is gone, they don't tend to have that same support. So again, they have that high risk for them to redevelop. So again, even when you're trying to do a healing wound, if you're not getting rid of this callus, you're kind of fighting an uphill battle. So again, hopefully you can reach out to one of your local NSWACs and have this looked at. Again, there is private pay available that patients can have, but reducing callus, wherever there's callus, there's pressure. So we do have to try to reduce that so that, again, offloading is another big piece, but we'll talk about when we cover diabetic feet. However, removing that callus is kind of the key to start to get a good healthy wound bed. You can see where the base is, and then we can actually start to get some healing. So that's kind of the gist on EDGE. Again, I will go through it a little bit more when we do the BWAP, because I do think that's also a really great tool that we should go through that lots of people see, but we don't all use. Anyhow, right, remember, best wound is a closed one. Catch you in the next episode.